As more patients are being offered MOGA and we are learning more about its effectiveness, are folks able to take breaks and resume treatment when necessary with success? We always seem to get a lot of questions on MOGA, and this is a common one.
Very good question. Yeah, it's a great drug, and we're so thankful to have it approved and now being widely used. And it's well tolerated. Hopefully, there are not a lot of reactions and side effects. So if someone is having a great response um, uh, and is looking for a different schedule, I have been able to lengthen the amount of time between doses from every 2 weeks, and then we might move to every 3 weeks, and then possibly 4 weeks. This has to be done under close supervision of your treating oncologist. What I find is that out in the community, um, if a patient is getting this drug through their local oncologist, they're not monitoring the skin as well as in our multidisciplinary clinic. So I would make sure that there is good skin follow-up with the dermatologist managing you, just to monitor if there is any breakthrough of any new lesions on this new schedule. Um, I've been successful doing that with other drugs, including a drug called romidepsin, which was also in a very similar schedule, um, and that is not an antibody treatment, but we were able to increase the intervals for patients who are responding. Since mogamulizumab is an antibody treatment, it's a monoclonal antibody, it does stay in the system for longer, up to 90 days, in fact. So I do think it lends itself well to other schedules, but again, under close supervision.
Yeah, and we've had a very similar experience to Dr. Lansigan. So, as you mentioned, with other drugs, we've done it with romidepsin as well and pralatrexate, and even with Doxil, where people are doing well, we like to give them a bit of a break and spread out the interval if possible. And as he mentioned, close follow-up is key. So if anything reverses or any lesions start progressing or coming back, we see the patient straight away.
Another MOGA question: what side effects have you seen with this treatment? Any that affect vision, for example, or joint pain?
The ones I've most commonly seen are rash, the kind of red rash that happens quickly, infusion reactions. Those are the two main ones, and increased risk of infection. I haven't come across ones with vision, but I'd be interested to hear what Dr. Lansigan says.
Yeah, so mogamulizumab, it targets a protein called CCR4, and so some people, so some patients might react in a way that it causes what we call autoimmune disease, and so the joint pain could be something that's related to something autoimmune going on. And I have seen side effects where the mogamulizumab has caused an autoimmune arthritis, and then stopping the drug that tends to resolve. So the other thing with vision is that there can be some autoimmune diseases that affect the eyes. Typically, it's more like a dry eye type of side effect, and something called Sjogren's disease. That would be the autoimmune disease affecting the eye. But vision itself I have not seen many patients with specific visual complaints. But it's certainly worth looking into if you've been on the MOGA, and this is something that's a recurring problem or a new problem since starting the mogamulizumab.
Is there any merit to epidermis radiation?
Yeah, so we consider the total skin electron beam radiation as a very good treatment for large cell transformation and tumor stage cutaneous T-cell lymphoma. This needs to be given in specialty centers that have electron beam So you have to ask your facility where they deliver this type of treatment and if it's available in your facility. It is a good treatment. It is a very involved treatment. It does require a lot of expertise because there are different schedules that can be tried. We tend to use an abbreviated schedule in the beginning to see what the response would be, because there are side effects to the skin when you do total skin radiation, and it's a whole procedure which requires expertise and positioning patients in certain ways. So all the electron beams hit the entire skin, and that's why it's called total skin electron beam radiation. And it's very effective at controlling the disease, but often after that radiation is given, some sort of maintenance therapy needs to be given as well. And that maintenance therapy can be uh, ECP, which is photopheresis, which you may have heard of. Extracorporeal photopheresis is the full name. Interferon could be used as maintenance if tolerated now. So that would be a good reason to try the interferon for tolerability, and it could be maintained after radiation.
I just, Dr. Lanskin gave a very detailed explanation on total skin electron beam. Another way to use radiation is just for localized disease. So if you don't have tumors all over, perhaps they're just localized to a certain body part or a limb, that can be targeted very easily by the radiation. And typically, the CTCL, it's very radiosensitive, so you can get very good responses. And because they use superficial electron beam, you can actually radiate that area again if another lesion comes up close by. So that's a good way of doing local disease.
In particular treatments like steroid creams, light therapy, and radiation are thus far controlling the disease. Is it best not to deviate from that with experimental treatments like clinical trials and drugs? It's a little bit of a toughie on that one.
I don't know what Dr. Lanzigan feels, but I feel that, you know, if something is working, I would stick to that. And you know, at some point, some of these with the lymphoma, some of these treatments stop working eventually, and so you don't want to use up all your resources up front. And I think it's better to keep on to one method if it's working very well.
I completely agree with that. You know, as I lead the clinical trials program in cutaneous lymphoma and blood cancers, we very carefully select patients and would only offer it if truly needed. And yeah, so I don't tend to deviate from things that are working really well, and only offer things when we think that it's needed, if the disease changes or progresses. That would be a time to look for experimental options if they're available.
Are there any new treatments available or in the pipeline? There's always something in a clinical trial somewhere.
Yes, we're participating in clinical trials at Dartmouth. We're enrolling patients into a trial with a drug called lacutamab. It's an antibody, monoclonal antibody that targets a protein in the something called the KIR family. And this is recruiting patients worldwide. And so I join all the calls to see how the enrollment is going, and what is the clinical experience. And in our experience, patients are starting to show some responses, and it's going to be another drug that will be evaluated for approval based on the data. So yes, that is one clinical trial that you couldn't get access to at your local, at your nearest academic center or place that has this trial available. We have it open here, and maybe Dr. Sani and other institutions in Boston have it open as well.
For a patient you've treated with romidipine, I can always say that one, romidipine, still can't get it, who have achieved a complete remission, thank you, complete remission with no sign of disease, have you ever discontinued use, and if so, for how long? And it's a multi-part, so we're going to leave it up for a little bit. Did the remission continue? My mom is now taking it every 9 weeks. Complete remission for nearly 7 years. Romidipine.
We've had a few patients who've done very well, and then we've done the same things. We've tapered off the dose, and then longer and longer, and then kind of given them a break from the drug. I think it's better if you can put them on some sort of maintenance treatment, something like extracorporeal photopheresis, just to help prevent the disease from coming back or to prolong the response. But as Dr. Lansing had mentioned before, we want to keep those patients under close review. They should always have our contact number in case something is breaking through. But definitely we've had full responses.
I agree with that comment completely.
I heard it's not suggested to cut out nodules, papules, bumps in the skin. I would like to know why this is the case.
So typically with mycosis fungoides, with LYP, I'm trying to think of any, with cutaneous B-cell lymphoma, all the ones where you can get papules, nodules. Typically, if you just cut one or two out, it doesn't affect the kind of pathway or progression of the disease. And what you end up doing, if that's all you were doing, you'd be chasing it. You'd be cutting one, another one would appear, and cutting that, another one would appear. And so, more importantly, you want to attack the whole disease itself with a drug or with radiation therapy and kind of stop it from starting up in the first place.
It makes sense. All right, our next question, with brentuximab, if peripheral neuropathy occurs, is it reversible and can treatment be restarted?
Yes. Good question. Thank you for the question. Yes, peripheral neuropathy is the most common side effect from brentuximab, and it was something we monitor very closely. Different studies have shown that it is reversible. Studies in Hodgkin's lymphoma, studies where this drug is used a lot as well. And if you stop it, it can reverse, but it takes time. It does take time to reverse, and it may not reverse all the way. So that is something to watch out for, and let your doctor know that it's happening so they can intervene and reduce the dose, because there are different dose schedules and dose levels that can be tried to prevent that from getting worse. Some other things that you might want to know about is that my practice is that vitamin B6 is something that I prescribe patients who are getting neurotoxic agents, and at a dose of 50 to 100 milligrams a day, that there is some evidence that can prevent neuropathy. So you might want to consider just going on a vitamin to prevent this, and to maybe even help reverse what's already.
What is your experience with mogamulizumab for treatment of Sézary syndrome? How long is the effect of the infusions after stopping, and how long is treatment given?
So I can address that. So we've been very fortunate here in Calgary and Alberta to have access through the new therapy of mogamulizumab for the treatment of advanced mycosis fungoides or Sézary syndrome. So for those in the audience that may not have heard of this particular therapy, it's an antibody directed against a certain chemokine, which is like a chemical signal that tells the tumor cells to migrate to the skin. It's exciting in that it is one of the only drugs to have been tested in a randomized phase 3 clinical trial to help shape our treatment selection for patients living with these diseases. Within Canada, it's gone through a special process to have it recommended for funding in each province across Canada. but there is currently not widespread access to the drug. The company is working on some remediation within their manufacturing, as I understand. But that is soon to be more widely available in the close of 2023. Mogamulizumab is a therapy that we've used quite broadly with great success for our patients living with Sézary syndrome in particular. I think the question was specifically around how long does the remission duration last after stopping the mogamulizumab. So I'll get to that in a moment. Oh, thank you. Someone just popped it back up on the screen for me. Yes. So the protocol for mogamulizumab is to take the infusion once every two weeks. In our experience, patients who've had significant skin involvement with their Sézary syndrome, blood involvement with their Sézary syndrome, and related symptoms have experienced very prompt response with improvement of symptoms and all those clinical parameters within a few cycles of the mogamulizumab. One of the open questions for us as providers that will be answered with further experience and possibly new trials will be, when can you safely reduce that frequency of mogamulizumab to an infusion every 2 weeks to something more achievable long-term, more like a maintenance protocol of mogamulizumab. So we have continued with the protocol that was written in the original clinical trial of every 2 weeks for patients that are able to tolerate that. And we continue it so long as it's working. Dr. Harden may be able to chime in about her experience through the United States, where some larger cutaneous lymphoma centers have started to look at creating more of a maintenance protocol for the mogamulizumab.
Yeah, definitely when I was away, and the work towards sort of publishing this literature so that it can be sort of more widely used across the world is underway. But again, with only handfuls of patients, and as you can imagine, all the patients that are on mogamulizumab have been treated with many things, and often mogamulizumab is still used concurrently with other treatments, such as extracorporeal photopheresis or interferon. But yes, while I was away, there were centers that were kind of tinkering with reducing frequency of mogamulizumab to every month, or sometimes extending it longer in certain patient circumstances.
What are some new treatment options for advanced cases with lesions, plaques, small tumors, and intense itching? And we all know we're always looking for a cure and what's the next best treatment. And as a rare disease, sometimes new treatments can be slow coming. So didn't know if there's any new ones on the horizon either of you have had any experience with.
So I think the question, I guess, is sort of two parts. One is about the symptomatic management of pruritus or itching. And that's an experience that a lot of patients have with mycosis fungoides or even related Sézary syndrome. And it can be very troubling and impact on quality of life. So it's really an excellent question to bring forward, the challenge of itching for our patients. So the first thing is to make sure that there's adequate skin care, so skin health, whether that be proper bathing, cleansing, as well as topical corticosteroids can improve skin itch for some individuals. As well, for people with advanced severe itching, it's important to be on the correct systemic therapy, and we'll maybe reserve sort of the details of which systemic therapy would be recommended in that situation a little bit later, but to sort of focus on the supportive care things we can do for individuals with itch. Many patients have benefit using the class of medications from gabapentin or pregabalin are quite helpful, so we'll try those. As well, sometimes people will benefit from antihistamines, and there's some antihistamines that are safe to use and can aid in people sleeping when they have significant itch at night. And maybe I'll just let Dr. Harden jump in with any additional skin modalities.
Yeah, I think in terms of skin-directed therapy, some of the newer agents that we are getting access to, so in Canada, we previously had very limited access to sort of topical nitrogen mustard and its derivatives, and we now have, it's called mechlorethamine gel. This is widely available in the United States, but more recently has been under review here, and unfortunately, we have access to it only for patients who have private health insurance that can cover it currently, so it's not currently covered under our provincial health plan, but this is one that is an old treatment, but that is new to us. And then there have been some more studies around photodynamic therapy and the use of that also in cutaneous T-cell lymphoma that are still in early phase clinical trials in the United States as well. That's something we're kind of watching out for or looking for because we maybe would have access to that here also.
Is gemcitabine plus methotrexate a commonly used and effective treatment for advanced stage disease?
I can take this one. So I'll handle it in two parts and then address them together. So methotrexate or low-dose methotrexate, that being either a small oral dose administered on a once-weekly basis or a subcutaneous injection of methotrexate, is a therapy that we use sometimes for cutaneous T-cell lymphoma for an individual who perhaps has progressed through topical therapies or skin-directed phototherapy, or simply unable to access phototherapy for reasons of geography, for example. In our hands, it hasn't always been a very effective therapy, so we generally recommend other treatments like retinoids or interferon, which we haven't spoken of yet today. Methotrexate is also used for patients who have a subtype of cutaneous lymphoma called lymphomatoid papulosis. So if patients have frequent recurrent involvement in areas that are difficult to handle, such as the face, individuals might think about being on a low-dose methotrexate almost as a suppressive or preventative strategy to prevent the development of new lesions. And similarly, we use that sometimes for people with anaplastic large cell lymphoma of the primary cutaneous subtype who have had frequent recurrences of tumors of that type. We will use the low-dose methotrexate. Gemcitabine, on the other hand, gemcitabine monotherapy as a single-agent chemotherapy is a treatment that we use and have funded and available in Canada for advanced stage mycosis fungoides. So this would be an individual who has multifocal tumoral stage MF that has progressed through other therapies, or somebody who has organ involvement of their mycosis fungoides, whether that be lung, liver, kidney, or extensive nodal disease. So gemcitabine generally is our go-to first-line systemic chemotherapy agent in those settings. Although it can be effective initially, one of the challenges with systemic chemotherapy for mycosis fungoides is relapse after discontinuation of the treatment protocol. So for anyone who goes through gemcitabine monotherapy, the full treatment protocol is approximately 4 months in duration, or 4.5 months in duration. And it is common that even if an individual has their MF remit after that particular chemotherapy protocol, unfortunately, it typically relapses within a year after finishing it. So the decisions to start systemic chemotherapy have to be really carefully considered for those reasons. And it's not always the easiest treatment to tolerate as well. I personally have never used the two in combination. I don't know if that's been studied in some jurisdictions, but the two at the same time would be sort of an uncommon systemic therapy. And there would be just overlapping toxicities to take into consideration that would have to be monitored closely, specifically myelosuppression or reduction in blood cell counts. So I think that would be less common that those two are used simultaneously, but maybe in sequence of one another.
They have been on continuous treatment with MOGA since October of 2020, and they've had 6 previous protocols. They're doing well and have had a complete response and spacing treatments to 7 weeks apart now. But they have begun experiencing muscle and joint pain while all inflammatory markers are normal. Have you had this experience with any of your patients? And if so, what was your suggestion?
So mogamulizumab is an excellent drug, and I'm glad the patient who was asking the question had such an excellent response. I mean, that's really wonderful to hear. We do face this problem now a lot more often than before, that we have patients on drugs that in clinical trials have been used in time-limited fashion, and it's not clear entirely how long we are supposed to use this drug. So there are variations in provider preferences, meaning some providers stop after a certain period of time, and some providers continue. And our practice has been based on the response to continue, but then to lengthen the times in between the infusions. And there are clinical trials also looking at that strategy to formally assess whether that's a feasible strategy. What I would say is, if we can establish that the symptoms that the patient is experiencing are related to the mogamulizumab and the patient has achieved an excellent response to the therapy, it may be worthwhile to consider a treatment break. Sometimes, we do know that mogamulizumab can be associated with autoimmune disorders. And there can be some unusual autoimmune disorders, and some of them might not have been captured in the clinical trial. So there are always some side effects that might occur at a later stage, which is why, for example, the FDA collects a lot of this information when drugs have been approved. But I think an appropriate workup to see whether there is an inflammatory component, and it sounds like the patient had that workup, is indicated. And if nothing else can be established, and the patient continues to have an excellent response, particularly in the blood and the skin, and I think a treatment holiday might be a good idea, figuring it out, because if these symptoms disappear, then it may be connected. Clearly, we only would know if we then re-challenge and they occur again, truly, if the mogamulizumab is a factor. But as there is no clear evidence supporting indefinite use of mogamulizumab, I think a treatment holiday would be what I probably would advise. But again, I don't have the full picture, and it sounds like there have been many prior clinical trials or regimens that have been tried. So it sounds like probably that is the reason why the drug is being continued, because it might have been hard to keep a remission in the past. So that has to be taken into account. But a drug holiday certainly is something one could discuss at this point.
Pros and cons of MOGA. I know we've talked about it already, but they're specifically looking, in your opinion, what are the pros and cons?
Well, the pro is that it is an immunotherapy. So we are strong believers that modulating the immune system is really important in patients with cutaneous T-cell lymphomas. And patients, when they get diagnosed, often are very immunocompromised. If one looks at the different types of T cells, so the T cells prime job is actually to fight off infections and or even other cancers, and there should be a whole lot of these different types of T cells that fight different infections. When one looks at what's called the T cell repertoire in patients with cutaneous lymphoma, and particularly often also Sézary syndrome, all we find often is one type of T cell, and that's the cutaneous lymphoma T cell. And so patients are at the get-go very immunocompromised and are more susceptible to infection. So finding therapies that do not further put a strain on the immune system is really important. And that is the pro of mogamulizumab, that it does work directly by targeting these abnormal cells to the immune system. It helps the immune system identify and destroy them, but it also works in other parts of the immune system and kind of take some checks of the immune system that the cancer cells have developed to keep the immune system quiet or to escape the immune system. So that's another good part of the mogamulizumab. The other pro is that it's a very well tolerated drug in general. While it does have a rash as a not uncommon side effect, and that certainly can be confusing, this usually can be fairly well managed by providers that have experience with this drug. But in general, it is a very well tolerated drug. The last pro I would, well, there's several more pros, but one other is that it works extremely well in patients with blood involvement. It's amazing, especially compared to when we did not have mogamulizumab around. That was often a challenge, and in this compartment, the mogamulizumab works very well. That brings me also to the cons that it of course, it can be a strain on patients, having initially this once a week infusion for 5 weeks and then every other week. So it can be involved. And the fact that it does, well, every drug in cutaneous lymphoma works better in one compartment than in the other. So it's not the right drug for every patient, for example. So we have to look at what the main symptoms of the patients are, which areas are the main ones involved, and how we can treat that best. Lastly, I think that though that is another pro, one can combine mogamulizumab with other therapies, and that certainly is a pro of several other drugs. But certainly we have, as Dr. Park has pointed out, tried other multimodalities therapies. So, for example, one can combine it with photopheresis. One can combine it with phototherapy or skin-directed phototherapy. One can combine it with radiation, and we do combine it with other drugs that can stimulate the immune system. And there might be some synergy, so not just 1 + 1 is 2, but there might be 1 + 1 is 4 that we think with combining these immunotherapies, so they really bring out the best in each other. So a lot of pros. Any drug has cons. The drug rash can be sometimes challenging and may require biopsy. But all in all, I think it's been a big advancement in the armamentarium to have mogamulizumab around.
What kind of successes have you had with bexarotene? And then on her question, was anybody have a full body scan radiation? So I guess I would rephrase that question is, when would that be something that we would want to have done with the patient? So if we want to split it into overall success you've seen with bexarotene first.
Yeah, I mean, I think that the clinical trials, you know, the overall response rates around 30 to 40% with bexarotene. And in general, that's what I typically see in my patient population. With regards to when total skin would be appropriate, So I think about using total skin in patients, depending on what they've tried already, how symptomatic they are. Total skin tends to be a pretty fairly quicker acting kind of therapeutic that we reach for. So in patients who are highly symptomatic, very itchy, have quite a bit of body surface area involvement, I will typically kind of talk about that as an option, but it's kind of a shared decision-making process with my patients and what they feel comfortable doing and how symptomatic they are. So if they've failed, all the systemic medications that I've typically offer, like bexarotene or interferon, certainly the other skin-directed treatments, then I will kind of push that. And then, the other thing is if they don't have available access to things like PUVA, which tends to be a little bit more effective than narrowband UVB, and they're again highly symptomatic. Typically what we do now with total skin is low dose, so that can be kind of something to reach for as well.
Yeah, I think that's a very comprehensive answer. Absolutely. We do, when we think about total skin electron beam radiation or total body radiation, we think also sometimes about what the future may hold for the patient. So particularly if we have somebody where we think about an allogeneic stem cell transplant in the future, where we do know that we also will use total skin electron beam therapy prior to the transplant. We'll have to consider that. But as Dr. Park has pointed out, we have been using lower and lower doses of total skin body radiation, particularly here at Penn, and those can sometimes be even repeated 1 or 2 times in patients. And we've had often seen very good responses, particularly in some patients, as Dr. Park has pointed out, who are highly symptomatic and have erythroderma. And we often consider this also as part of a multimodality approach, so not only just one therapy. And another important part is that with the total skin radiation, we do know that the responses can last a variable amount of time. And we do know that after that, we would like patients to receive some form of maintenance therapy to maintain that response for as long as possible. And this just shows how important the multidisciplinary approach in this disease is, where the dermatologist talks to the radiation oncologist and the medical oncologist, and then, of course, also takes into account the patient's opinion. The other thing is availability of total skin electron beam therapy may not be the same for wherever one lives in the United States. It can be sometimes very difficult for patients to identify locations, but I know that the Cutaneous Lymphoma Foundation can be very helpful in locating those centers that offer this therapy, if that ever is considered.
Yeah, that's a great point, Dr. Barda. And then the only other thing I would add is, at Penn, we do a lot of multimodality therapy, and combining total skin with things like interferon can really help potentiate the effects of total skin. And we've seen some really nice response in terms of kind of stimulating the immune system following radiation.
What is new in treatments? And then how close in our future are successful treatment options for remission? So it all kind of goes together. Can it be cured? And if it can't be cured, what do you see on the horizon that's promising?
So maybe I'll take a stab at this question, and if Dr. Park has something to add. But in terms of cure, at this point in time, the only modality that we think can cure cutaneous T-cell lymphoma is an allogeneic stem cell transplant. So that is where patients receive the blood stem cells from another person, and with that also receive a new immune system. clearly it has significant risks, and works better for some patients than others, and may not be an option for patients who have other medical illnesses that increase the risk of side effects from the transplant. So this has always been weighed against each other, the risk of having significant complications, and some of those are long-term complications, and against the benefits. Certainly, we are looking into other immunotherapies that may have the potential for a cure. So, for example, there are some CAR T-cell therapies that are being explored in T-cell lymphoma. So these are therapies where the patient's own or somebody else's T-cells or other immune cells, for example, NK cells, are being modified to recognize the accessory cells and then are being infused. So that's slightly different from a transplant. But these are currently just investigational and experimental. And then last but not least, there are always some patients who have an exceptional response to a therapy. For example, some patients can have an exceptional response to photopheresis and interferon, to particular immune therapies, and remain in a remission and never relapse. Whether they are cured or not, that's then a philosophical question. But if one has no disease for a very long time and never relapses in their lifetime, that's good enough for me. And we can see that sometimes with certain immunotherapies, and photopheresis may be one of them. With interferon, some drugs like pembrolizumab can offer some exceptional long-term responses, and even some patients with other therapies, like combination of mogamulizumab. There's always, when you look at clinical trials, there's always a tail to the curve.
What are the latest research findings on treating cutaneous marginal zone lymphoma?
Okay, I can take this. So I think the most interesting research finding is that the cutaneous marginal zone lymphoma was kind of changed. The definition of the cutaneous marginal lymphoma was changed to a lymphoproliferative disorder, and this really makes you think how things are evolving a little bit, meaning that that we are understanding more and more that this lymphoma doesn't really go inside of the body, is not really a big threat for the patient's life. What we are doing here, which I think is very interesting and a little innovative, is we are doing a 2-gray radiation, which is a very low amount of radiation. And I really like that, because the patients get their lesions out, and they don't really get any side effects from that radiation. Other things that can be done are the Rituxan intralesional injections. And that can be an option, and sometimes it works really well. And then ultimately, there's not big new drugs on the horizon, unless Dr. Geller has better news, because it really is it really is quite an indolent disease, and again, it's not called lymphoma anymore, but lymphoproliferative disorder. So I think that's very reassuring.
Yeah, so I totally agree. I mean, there is no big news in this field, specifically because it's becoming more evident that it is something that is, more inflammatory and less neoplastic, less cancerous. We do try to treat it when it's like areas that are of big concern to the patients, like specifically cosmetic concern, like on the face or on the hands. But we have patients that have like lesions or multiple lesions on the trunk, and if it's undercover and it's not too, bothering to the patient, we can also monitor this lesion We can use some topical steroids or intralesional steroids also that are helpful sometimes. So it's something that has changed in the last few years, the approach to this specific subtype.
Are there new therapies in the pipeline?
For mycosis fungoides?
For anything to do with cutaneous lymphoma, we're always looking for, what is there anything that you know of, any clinical trials that either of you are participating in, anything that you can share that you hear about what's coming?
Well, I think
and if the answer is no, we know this is a tough disease, so don't feel like you have to come up with something.
I think the most exciting ideas and trials come really from the immunotherapy. We were initially pretty skeptical and a little scared in doing immunotherapy for these lymphomas because they're still T-cell lymphomas, right? And in some of the diffuse T-cell lymphoma, the systemic T-cell lymphomas, drugs that stimulate the immune system have sometimes produced hyperprogression of the disease, but it seems like in mycosis fungoides and CTCL, really this doesn't happen. And so we're running a couple of clinical trials. Some of you may have tried this drug called mogamulizumab. That's already in the market, and we have it, and it's one of those drugs that really work with the immune system to train it to go against a lymphoma. And here, for example, we are combining it with another drug that stimulates the immune system in another way, in a slightly different way. So that's really exciting. Other medicines that we can use right now for mycosis fungoides and Sézary are the checkpoint inhibitors. Sure, this is not really the front line or not even the first 2 or 3 lines, but certainly it's an option for the patient that's becoming more interesting, as well as the bispecific antibodies that have been used a lot in the B-cell lymphomas. And now there are a couple that also can target cells like mycosis fungoides and Sézary. So that's one really, really new field or new way of treating the disease. And then there's also this LAG3 antibody that's new within the last 2 or 3 years. It's been there's a couple of reports showing very good results. So that's another drug that I think has potential. And then really, we are doing clinical trials with all the drugs that we use for the peripheral T-cell lymphomas to see if they work as well in the cutaneous lymphomas. And sometimes it's really similar, like we see responses in both. And some of them are pills, which is really great. And, whatever has a very low toxicity and very good results is what we are looking for. And for drugs that have a little bit more toxicity, like for example, the brentuximab, we are doing trials where we lower the dose at the minimum level. And that may help with the toxicity, but still preserve the response. Ultimately, this is all in trials, so we'll see the results pretty soon.
Yes, I can add to that we are trying, because we have, our toolbox is not, as full as in other, cancers, but we do have some good drugs that we can offer in different stages. And currently we are doing some trials that try, as Dr. Ghioni said, to see how we better or optimize the way that we use these tools. So for example, for patients with more early stage disease, we have these trials that we give them full body radiation with the low doses, and then once we get clearance, rapid clearance of the skin, they can we combine that with bexarotene, with targetin, which gives us long remissions or long control over the disease. So doing these trials of using, like, some of them are older or like new, and some of them are newer approaches, but doing the combinations, this is another step in, trying to get to better treatment and better care for patients. So this is something that is not like new therapies, but it's like new approaches or new uses of the old methods and old medications that we know.
Okay, thank you. And I think you are addressed what our next question. The only additional piece on this was they're asking if there's any medication or creams to avoid.
That's actually a good question. There are certain drugs that you may not want to take that would lower your immune system further. Medications like cyclosporin could certainly be an issue if you have a cutaneous T-cell lymphoma that would potentially allow the T-cell lymphoma to become more aggressive. So certainly talking to your doctors when you start any new medication that you have to take orally would be important to kind of let them know you have this diagnosis. Creams, some creams can be irritating and cause more inflammation. So if you're experiencing irritation with some of the creams, you would want to stop them if they're just really irritating their skin. Now, some people do have allergic contact reactions where they're actually allergic to creams. So if you're experiencing a lot of rash and itch when you're applying a cream, talk to your doctor. It could either be an irritant or an allergy, and you can sort through those things with your doctor.
When is it typically time to consider moving from skin-directed therapies to a systemic treatment, oral or injectable?
I can start with this because you'll start with the dermatologist. So certainly when you're doing skin-directed therapy, we're looking at multiple factors. One is, what areas are involved? Is this something that's really affecting your quality of life? Is it something we need to move faster with progression? How are you responding to the therapy? Now, having said that, skin-directed therapies are not instantaneous. They take a while. They can take up to 3 months to really see some benefit. So you do have to be a little bit patient when you're doing skin-directed therapies, but it's an open dialogue with your treating physician to talk about what your goals are and how it's affecting your life.
Thank you. Dr. Sethi, what would you like to add to that?
So I absolutely agree with that. I think even when it comes to systemic therapies, when they are introduced with, especially with mycosis fungoides, the time to treatment response can be a few months. So definitely patience is the key, and our ultimate goal is to direct our therapies and sequence them in such a way where it really improves the quality of life for our patients.
What is the best treatment for recurrent cutaneous B-cell lymphoma? I've had 5 incidents of cutaneous follicular B-cell lymphoma in 5 years. 4 were treated with radiation. I'm currently awaiting a second opinion on treatment and curious about the best course of action. And this is a good spot as the reminder, please do not consider this a second opinion as these doctors have not seen your records.
Okay, I can answer that. With as you described with cutaneous follicular B-cell lymphoma, definitely recurrence is an issue. It is a very treatable cancer, but it is not curable, and so we do deal with the situation. In general, what we recommend is if it is at a site where it doesn't if it's not growing aggressively, or if it is at a site that it is not bothering you, we can often monitor it. We don't have to treat it right away. But and there are other circumstances, especially if you have more than one lesion or the radiation alone, local therapy is not helping, then treatments like rituximab, which is an antibody drug, can be pretty effective in this situation.
Is there any new information on LYP or MF to help us heal quicker or not get the lesions in the first place? Other than chemotherapy drugs and UVB therapy, are there safer alternatives? So there's always that question on what are the new therapies that are out there for us?
I guess Dr. Burgeon, do you want to start?
Sure. I mean, it's still a very exciting time in cutaneous T-cell lymphomas and lymphomatoid papulosas. There are a lot of studies going on and drugs that are becoming available. Certainly places to look are like clinicaltrials.gov to kind of look at the studies. And if you're interested in studies, that might be a place to see if you qualify and where the studies are going on. It really depends on the stage of disease, what would be a good choice for you. Lymphomatoid papulosis, remember, is still considered in the benign spectrum. I don't think there's quite as many new developments in lymphomatoid papulosis as there is in cutaneous T-cell lymphoma. The newer drugs tend to be more focused on people who have more progressive disease or recalcitrant disease. And often we do work with our oncology partners to kind of was available. And they tend to be more targeted therapies now. It's not really traditional chemotherapy. It's really much more kind of focused on the pathways of the actual lymphoma to target different proteins or markers on the cells to really try and also boost up your immune response to your lymphoma. And Dr. Sethi, I think, does some of the research on this, so I could let her actually add a little bit more response.
No, absolutely. And, definitely in the CTCL mycosis fungoides world, I think we have had, newer drugs come through, which is very helpful because, this is a chronic disease. We have to sequence therapies, and the more options we have, the better it is. Mogamulizumab is an antibody drug that, that was approved a few years ago and is very effective in Sézary syndrome. And then again, in this day and age, we do have an idea as to what, depending upon what kind of lesions and the extent of disease, some agents work better than the others. And we do have some trials even at our center right now enrolling, including immunotherapy trials using checkpoint inhibitors in cutaneous T-cell lymphomas.
What are your thoughts on methotrexate?
So it depends upon what type of lymphoma we're talking about. So methotrexate methotrexate works pretty well for lymphomatoid papillomatosis. It also works for certain cases of other cases of cutaneous T-cell lymphoma. However, a lot of mycosis fungoides patients if we think about using methotrexate, we usually prefer an agent like pralatrexate, which is kind of more effective in this disease. But methotrexate definitely does have a role for some slow-growing, processes that we see in the skin.
What is the best to use for weeping skin?
So that's a great question, because a lot of times people will find their skin is just kind of oozing and weeping and miserable. There's different ways you can approach that. Certainly, even though it's weeping, sometimes you're losing a lot of your skin barrier with the weeping. Vaseline, again, can be nice because it can help be a good moisturizer that doesn't tend to burn on weeping skin. Also, it's something that helps to try to prevent infection in skin that's weeping. Sometimes compresses can be very helpful to kind of treat weeping skin. There are different types of compresses. Sometimes we'll use like vinegar compresses to kind of help. Sometimes bleach soaks can help with weeping skin. It really depends on what type of weeping. You should talk to your doctors to see if there's any evidence of infection in the weeping area so they can come up with a plan with you to try and kind of help that weeping.
What can you recommend to prevent or alleviate bruising of skins, primarily on the arms and hands?
So this tends to mostly be something that we call, it's got a pretty name, solar purpura. So when we see a lot of bruising on the hands and the arms, it tends to be as we head towards our prime in life. And if we've used a lot of skin thinning agents like topical steroids, the collagen that used to support our blood vessels isn't very strong anymore. So we can sometimes just tap our hand or just hold a box, and just the pressure from holding the box can cause the blood to leak out of the blood vessels and into the skin. So it's very common to see that bruising on the hands and the arm areas where there's a little bit more trauma. So avoiding trauma when you can, again, we discussed kind of thinning skin earlier. It's very difficult to reverse any thinning. And once that collagen is kind of lost, there is some information about citric acid supplements, like vitamin C supplements that are out there. I've never really had great results with them, to be honest with you, and they can be fairly expensive. So really just kind of protecting the skin can be one thing that you can do.
Generally, what is the most effective treatment in terms of success rate? I'm not really sure if you guys can answer that one. That one's tough.
Yeah, there are so many different answers depending upon, what stage of disease it is, and even with advanced stage disease, there are so much, there are certain drugs that work better for tumor type mycosis fungoides. There are certain ones that work better for Sézary syndrome. So it really, really is very different.
Do you have any suggested medication for breakouts on the face and on the scalp specifically?
So you do have to be careful in the face because the skin there is thinner and you are more prone to getting atrophy or thinning of the skin, like we talked about with some of the earlier. So definitely talking to your doctor, there are different options. There are weaker strength topical steroids that could potentially be used. There are, again, steroid sparing agents like topical bexarotene, or Targretin is the brand name of that could be used on the face and is not a steroid. The scalp, that's also tricky too, because it has to get through the hair for most people. So those are things that you often will have a liquid base to kind of put into the scalp and get down to get through the hair down to the scalp. So some things that we'll use are topical steroids that are in a solution base. A solution base is an alcohol base, so it tends to kind of get through the hair, get to the scalp, but it can burn because it has that alcohol base. Sometimes gels can also be a good base option. The gel is also alcohol based, but kind of thicker. And sometimes you can rub it in to kind of get into that area and have it dry more quickly. But both of those are very drying. There are different preparations in oil. Again, oil is very greasy, but it does kind of really get nicely to the scalp area. And certain scalps do better with oily kind of preparations than alcohol-based preparations. So there are different options to kind of get through the hair to the scalp. There's also some medicated shampoos that are out there. So there's different bases that we can use.